An 18-year-old woman is brought to the emergency department by ambulance for breathlessness. She has a past medical history of brittle asthma. What does that mean? And her GP noted her peak expiratory flow rate was 33% of her best. She is started on salbutamol and ipratropium bromide nebulizers as given and given hydrocortisone IV. Whilst your senior examines the patient, you take an arterial blood gas sample. The patient is receiving 15 liters of high flow oxygen. This shows the following: the ABG. pH is low, PCO2 is on the upper border of normal, PCO2 is on the lower border of normal, sodium is normal, potassium is low, chloride is normal, glucose is normal, lactate is it? Lactate is high, base excess is normal, bicarbonate is normal. What is the single most important next management step? What is going on here? So acidosis only slightly, CO2 is normal, sodium normal, potassium is quite low. I want to correct that. Administer a further dose of hydrocortisone IV, administer aminophylline infusion, administer magnesium sulfate, continue administration of salbutamol and ipratropium bromide via nebulizer, refer to ITU. Does she need ITU? PEFR is 33% of her best, which is severe, I think. Or is it life-threatening already? I want to correct his potassium because they are giving salbutamol, nebulized salbutamol. And I think it causes potassium to enter your cells. So you have hypokalemia. You want to stabilize the heart using magnesium sulfate. Is that the management for hypokalemia? Let's try. Nope, the answer is refer to ITU. Life-threatening asthma, PEFR less than 33, best or predicted. A PEFR of less than 33 best or predicted, along with hypoxia and normal hypercapnia on the background of known brittle asthma, is highly concerning for an acute, life-threatening exacerbation of asthma. It is vital to recognize the severity of an acute asthma attack and to escalate care appropriately. In this scenario, this translates to referring to intensive care staff early on. Occasionally, a higher dose of steroids may be administered in critically ill patients based on advice from seniors. This, however, is not based on evidence of effectiveness. Magnesium sulfate and aminophylline are appropriate treatments for life-threatening asthma. However, they should be commenced under supervision of a senior clinician. Okay, what does magnesium sulfate do? Does it actually stabilize in your heart in hypokalemia? Because that was my reasoning. I think maybe it doesn't. Therapeutic indications: treatment of magnesium deficiency and hypomagnesemia, treatment of magnesium deficiency where the oral route of administration may be inappropriate to prevent further seizures. Stabilize the brain activity, not the heart. Prevent further seizures associated with eclampsia. Pharmacodynamics. Mineral supplements. Magnesium is the second most abundant cation in intracellular fluid. So the most abundant is potassium, right? And is an essential body electrolyte. Magnesium is a factor in a number of enzyme systems and is involved in neurochemical transmission and muscular excitability. Parenterally administered magnesium sulfate exerts a depressant effect on the central nervous system. Parenterally administered magnesium sulfate exerts a depressant effects on the central nervous system and acts peripherally to produce vasodilation. Acts peripherally to produce vasodilation. Hypermagnesemia can cause the following ECG changes: prolonged PR, QRS, QT intervals. PR, QRS, QT, so it prolongs everything. Magnesium prolongs stuff in your heart. Okay. Oh, there's a reason in, how do you say? Is this the reason people with tumor lysis syndrome? Wait, I don't know. Tumor lysis syndrome, do you get these changes in your ECG? Since magnesium is in your heart, once you lyse the cells, magnesium comes out. You might have hypermagnesemia. Well, anyway, so magnesium sulfate is to stabilize your brain. It's used to prevent further seizures in preeclampsia. Not used in hypokalemia. So now I want to know what is the management in hypokalemia. Okay. Hypokalemia. Is there no official? Hypokalemia is not as dangerous as hyperkalemia, I guess. Hyperkalemia can cause the heart to rest in forever. So it can cause your heart to stop contracting. Hypokalemia, on the other hand, I don't know. The severity of the manifestations of hypokalemia tends to be proportional to the degree of duration of the reduction in serum potassium. Symptoms generally do not become manifest until the serum potassium is below 3. Unless the serum potassium falls rapidly or the patient has a potentiating factor such as predisposition to arrhythmia due to the use of digitalis, symptoms usually resolve with correction of the hypokalemia. Severe muscle weakness or rhabdomyolysis. Muscle weakness usually does not occur at serum potassium concentrations above 2.5. If the hypokalemia develops slowly, however, significant muscle weakness can occur at serum potassium concentrations below 2.5 or at higher values with hypokalemia of acute onset, as occurs in hypokalemic or thyrotoxic periodic paralysis. In addition, the pathophysiology of weakness in this disorder is more complex. The pattern of weakness in hypokalemia is similar to that of associated with hyperkalemia. Weakness usually begins in the lower extremities, progresses to the trunk and upper extremities, and can worsen to the point of paralysis. In addition to causing muscle weakness, severe potassium depletion, serum potassium less than 2.5, can lead to muscle cramps, rhabdomyolysis, and myoglobinuria. So instead of relaxing the muscles, it causes contraction of muscles. Muscle cramps, rhabdomyolysis, myoglobinuria. Potassium release from the muscle cells during exercise normally mediates vasodilation, and an appropriate increase in the muscle blood flow. Decreased potassium release due to profound hypokalemia can diminish blood flow to muscles during exertion, leading to ischemic rhabdomyolysis. The clinical and pathologic abnormalities are reversible in potassium repletion, a potential diagnostic problem that is the release of potassium from the cells with rhabdomyolysis can mask the severity of the underlying hypokalemia or even lead to normal or high values. Cardiac arrhythmia and CG abnormalities. A variety of arrhythmias may be seen in patients with hypokalemia. These include premature atrial complex, PAC, also referred to as a premature atrial beat, premature supraventricular complex or premature supraventricular beat, Looks like this, I guess. No. Yeah. Looks like an irregular rhythm, that's all. Sinus H reset. And here there are 5 P waves. As it mixed with the T wave. Oh, there are a few P waves here, mini P waves. And premature ventricular beats, sinus bradycardia, paroxysmal atrial or junctional tachycardia, atrioventricular block, and ventricular tachycardia or fibrillation. Hypokalemia produces characteristics changes on the ECG, although they are not seen in all patients. There is a depression in the ST segment, decrease in the amplitude of the T wave, and an increase in the amplitude of U wave. Okay, again, hypokalemia produces characteristic changes on the ECG, although they are not seen in all patients. There is a depression of the ST segment, decrease in the amplitude of the T wave, decrease in amplitude of T wave, and increase in the amplitude of U waves. U waves. I think the mnemonic is U have no pot and no T. So U is the U waves, have no pot, is low pot, means low potassium, I guess, and no T. T is a reduced amplitude. Okay, U waves are often seen in the lateral precordial leads, V4 to V6, called as prolonged QT interval. Oh, I suppose was I wanting to find out again? Oh yeah, what are the clinical manifestations? So these are the main ones. So your ECG abnormalities and rhabdomyolysis. It's not that dangerous. Not as dangerous as hyperkalemia. There's large inpatient variability in serum potassium concentration that is associated with progression of ECG changes or arrhythmias. In carefully controlled trial of thiazide hydrochlorothiazide 50 mg per day, there was a twofold increase in ventricular arrhythmias as detected by Holter monitoring in the small proportion of patients in whom serum potassium concentrations fall to below 3.0. In addition, the presence of concomitant factors such as coronary ischemia, digitalis, increased beta-adrenergic activity, and magnesium depletion can promote arrhythmias. The last two of these cofactors was a lower serum potassium concentration. Okay. So hypokalemia is not as dangerous as hyperkalemia. So I guess there is no guidelines on the management. There has to be, right? I mean, hypo. Why do you keep correcting me? Yeah, NICE doesn't have a guideline for hypokalemia. RCH. What's RCH? Royal College of what? Clinical Practice Guidelines. Royal Children's Hospital of Melbourne. It's Australian guidelines, I guess. General stuff will do for me. Potassium replacement indicated if potassium is less than 3, serum potassium less than 3.5, with symptoms of signs or ECG changes. Yeah, just replace potassium, that's all. Not much. Okay. Yeah, just replace the potassium. Put it in the fluids. Like how you add potassium chloride to your intravenous fluid infusions in DKA. Yeah, because when you're giving the fixed dose insulin infusion, you will force potassium into the cells and then cause hypokalemia. So you replace the potassium. That's all you do actually. Okay. How about salbutamol? How does it cause hypokalemia? The following 4 intravenous treatments were administered in a balanced randomized latent square design, 8 healthy volunteers, adrenaline. All active solutions were preceded by 1 hour control infusion. Control infusion will continue for 1 hour. Solutions, both active solutions, adrenaline and salbutamol, were increased stepwise to the above doses. Heart rate and blood pressure were recorded at frequent intervals throughout, and venous blood was taken for estimation of potassium, insulin, glucose, catecholamine, and salbutamol levels. There's no talk about mechanism here. The title is so misleading. Let's see if Sci-Hub can unlock. No. Has not been fully elucidated. Some authors have attributed it to the action of salbutamol on insulin release. A rise in insulin levels has been reported with salbutamol infusion, and insulin is released by stimulation of beta-2 adrenal receptors. The rise in serum insulin concentration could result in the shift of potassium into the cells from extracellular compartment, resulting in hypokalemia. Okay. This hypothesis must now be questioned. There is a membrane-bound beta-2 adrenal receptor-linked sodium-potassium ATPase on skeletal muscle cells, which causes insulin-independent potassium flux. Adrenaline-induced hypokalemia has been known for 50 years, but has only recently become the subject of intensive investigation. Pathophysiological increases in circulating adrenaline to levels similar to that of seen during acute severe illness, such as acute myocardial infarction or hypoglycemia, results in a fall in serum potassium of 0.8 to 1 millimole per liter, and the fall in serum potassium is prevented by beta-selective adrenal receptor antagonists. This discovery of the sodium-potassium ATPase pump linked to the beta-adrenal receptor stimulation has raised the possibility of an alternative explanation for salbutamol-induced hypokalemia. So it's on the muscles. Insulin-independent potassium flux. Okay, good enough for me. Do you have a conclusion, though? References? Discussion? The results of this study, why can't I zoom in? Never mind. The results of this study confirmed that both salbutamol and adrenaline alone or in combination can cause significant falls in serum potassium. The infusion regimens used in achieve steady state adrenaline levels 5 to 10 minutes, and the changes were observed and similar to those reported from our group and others with similar protocols. The salbutamol infusion regimen was designed for safety. As salbutamol has a long half-life, salbutamol levels rose throughout the infusion period, and we did not observe the maximum effect of this drug. The dose of salbutamol used in the study is not particularly high. Manufacturer dosage recommendation increasing maximum practice higher doses have been used. The management of premature labor is very likely that clinical practice intravenous salbutamol will cause substantial hypokalemia. While salbutamol produces a rapid and significant fall in potassium, there is only a small, slow, and statistically insignificant rise in plasma insulin. Insulin release is stimulated by the beta-2 adrenal receptor agonist. Do not support the view that a raise in insulin is the major cause of a large fall in potassium. Direct stimulation of beta-2 adrenal receptor linked to the membrane found in sodium-potassium ATP is the more likely explanation. Even this relatively low dose of salbutamol produces significant hypokalemia, and our results suggest that there is an additive effect of potassium with the doses of adrenaline we use, infused with raised circulating adrenaline levels to those seen in acute severe illness. There is no evidence of synergistic action on the potassium fluxes, and equally no evidence that either agent in doses was used maximally stimulating sodium and potassium transport. The observed additive effect is consistent with the view that the two agents act via the same mechanism. The rise in glucose during the adrenaline infusion is the result of alpha-2 adrenal receptor-induced inhibition of insulin release. Okay, so directly. Goody. What else did I want to know? Okay. Asthma, acute exacerbation of asthma management in different severities. You got moderate, severe, and life-threatening, right? It's life-threatening. PEFR less than 33. It is 33, which is at the threshold. So 33 or less. Here you have, well, I want to see guidelines. Oh, it's quite short. We just go through it. Acute asthma features. Acute asthma is nearly always seen in patients who have got a history of asthma. Features worsening dyspnea, wheeze, and cough that is not responding to salbutamol may be triggered by respiratory tract infection. Patients with acute severe asthma are stratified into moderate, severe, or life-threatening. Moderate, 50 to 75% best of PEFR predicted. Speech normal, respiratory rate less than 25, pulse rate less than 110. Severe PEFR of 33 to 50% best of predicted can't complete sentences, respiratory rate more than 25, pulse rate more than 110. Life-threatening PEFR less than 33% best or predicted, oxygen sats less than 92, silent chest, cyanosis, feeble respiratory effort, bradycardia, tachypnoea, or hypotension, exhaustion, confusion, coma. Asthma management. Then an appendix. Then we don't have to go through the whole text. Things here. Can I rotate? Oh well, there's so many. Which one to use? So this is management of acute asthma in adults in general practice. Management of acute asthma in adults in the emergency department. Management of acute asthma in adults in hospital. Emergency department is in the hospital. Management of asthma in children in general practice. Management of acute asthma in children in emergency department. Management of acute asthma in children in hospital. Infants aged less than 2 years in hospital. Work-related asthma, rhinitis, case finding and management in primary care. Okay, so we'll just do the adult one in hospital or in emergency department, because that's where most of the asthma is managed. Okay. Management of acute asthma in adults in emergency department. So first you have to measure peak respiratory flow and arterial saturations. So to do this, you need to do the ABG, right? So PEF of 50 to 75% of their best predicted is moderate asthma. SpO2 is more than 92. PEF is 50 to 75 for best or predicted. No features of acute asthma. PEF of 33 to 50% of best or predicted is acute severe asthma. Features of severe asthma: PEF of less than 50%, best or predicted. Respiration more than 25, SpO2 more than 92. So if SpO2 drops below 92, it's already life-threatening. Yeah? Pulse is more than 110, cannot complete sentences in one breath. And then you have the life-threatening asthma, PEF less than 33% or 33%. Okay, SpO2 less than 92%, silent chest, cyanosis, poor respiratory effort, arrhythmia, hypotension, exhaustion, altered consciousness. So how to manage each of these? If it's moderate, give beta-2 bronchodilator. There is a salbutamol via spacer. Give one puff at a time. According to the response, give another puff every 60 seconds up to a maximum of 10 puffs. So one puff at a time. Give another puff every 60 seconds up to maximum of 10 puffs. This is if it's moderate. If it's severe, you can give salbutamol 5 mg by oxygen-driven nebulizer. If it's life-threatening, you need to obtain senior or ICU help now if any life-threatening features are present. That's why over here they emphasize refer to ITU. Doesn't matter whether you want to give magnesium sulfate or not. Refer to ITU as soon as possible. And then your immediate management. These are the major management: oxygen to maintain SpO2 94 to 98, beta-2 bronchodilator with ipratropium, which was already given in the question, by a nebulizer, preferably oxygen-driven, salbutamol 5 mg, ipratropium 0.5 mg. Prednisolone 40 to 50 mg orally or IV hydrocortisone 100 mg. Measure arterial blood gases, markers of severity, normal or raised PaCO2. PaCO2 of more than 4.6. Severe hypoxia, PaO2 of less than 8. How is the PaCO2 here? PaCO2 is on a higher limit, upper limit. PaO2 lower limit. 4.6. Normal range differs here. Kilopascals. This kilopascals as well. Why is it more than 4.6? Oh, normal. Normal in inverted commas. The PaCO2 is supposed to be low. Yeah. Okay, so in somebody with severe asthma, right, they will be trying to breathe very fast. So when you breathe fast, you actually blow out CO2, and your PaCO2 should be low when you have asthma. However, when there is normal PaCO2, it means your respiratory effort is already affected. Yeah, it means you are going into exhaustion, altered consciousness, or poor respiratory effort, silent chest. Your air is not even getting into your lungs. So your PaCO2 is inappropriately normal or raised. So more than 4.6 is already alarming. It's already 6. 4.7 to 6 is the normal range. It shouldn't be in the normal range, it should be low. Okay, I missed that. Severe hypoxia. Okay, PaO2 of less than 8. PaO2 was 11. pH, low pH or high pH or high hydrogen. Okay, give repeat salbutamol. Low pH means you're getting acidosis, lactic acidosis, respiratory acidosis, and blowing out carbon dioxide. Blowing out carbon dioxide. Carbon dioxide causes acid, so it should be alkalotic. If you have low pH, it's already a sign of severity, a marker of severity. You shouldn't have any metabolic because it's all respiratory here. pH. Except lactic acidosis, I guess, since you're not getting oxygen, you're using alternative sources, so you produce lactic acid as a byproduct. Give or repeat salbutamol 5 mg with ipratropium 0.5 mg by oxygen-driven nebulizer after 15 minutes. Consider continuous salbutamol nebulizer 5 to 10 mg per hour. Consider IV magnesium sulfate 1.2 to 2 grams over 30 minutes. Correct fluid electrolyte, especially potassium disturbances. Check X-ray, chest X-ray, repeat ABG. Admit patient accompanied by a nurse or doctor at all times. If it's not so severe, over here I thought about a nebulizer. Over here you can just give puffs. Clinical stable and PEF more than 75. You can go on potential discharge. If patient is recovering and PEF more than 75, yeah, I can go on and discharge. And this all should take less than 20 minutes. You should go give all this already to act fast. Potential discharging. All patients who receive nebulized beta-2 bronchodilator, which is salbutamol, prior to presentation, consider an extended observation period prior to discharge. In PAF less than 50 or on presentation, give prednisolone 40 to 50 mg per day until recovery, minimum of 5 days. In all patients, ensure treatment supply of inhaled steroid and beta-2 bronchodilator and check inhaler technique. Arrange GP follow-up within 2 working days post-discharge. Fax or email discharge letter to the GP. Refer to Asthma Alliance nurse or chest clinic. Okay, if no signs of severe asthma and PAF of 50 to 75, observe and monitor SpO2, heart rate, respiratory rate. If patient stable PAF more than 50, you can potential discharge. Sign of severe asthma or PAF less than 50%, then you will want to admit. This is the normal estimated one. Signs of severe asthma, PAF less than 50. After all this has been given, you wanna give other stuff. Alright, there we have it. Management of asthma. So you have moderate, severe, and life-threatening. Notice there is no mild, acute exacerbation of asthma. Just moderate, severe, life-threatening. Moderate is 50 to 75% of predicted or best PEFR. Severe is 33 to 50%, and life-threatening is less than 33%. Other features include tachycardia and tachypnoea. Tachycardia is a pulse rate of more than 110. Tachypnoea more than respiratory rate of more than 25. Other than that, you can have in all of these you might have wheezes. In the severe one, you are unable to complete sentences. In the life-threatening one, the silent chest, you might be looking cyanosed or lethargic or confused. You might be even arrhythmia and hypotension. Okay. What else did I miss? Oh, SpO2. So whenever SpO2 is below 92%, it's already life-threatening. Because moderate and acute severe, it should be more than 92%. Okay, if it's mild, you can give salbutamol inhaler. Give 1 puff every 60 seconds, depending on the response. Up to 10 puffs. And if it's severe, then you give salbutamol via oxygen-driven nebulizer. And then if it's life-threatening, then you have to send to ICU, obtain senior ICU help immediately, and then give both salbutamol and ipratropium bromide via nebulizer driven by oxygen. Give oxygen to correct the hypoxia. Okay, the dose of salbutamol is 5 mg, and dose of ipratropium bromide is 0.5 mg. And you want to give prednisolone orally. If not able, you give 100 mg of IV hydrocortisone. Okay. Yeah, that's about it. And other markers of severity are here. And after that, you can consider giving magnesium sulfate, corrective fluids. So mainly it's salbutamol and ipratropium bromide and oxygen. Okay, so that's how you manage asthma. What else do I want to learn here? Normal PaCO2 in acute asthma attack indicates exhaustion and should therefore be classified as life-threatening. It's something I should not miss in the future. Okay, that's all.